The retrovirus HIV-1 is the causative agent of AIDS. Within a few years after recognition of AIDS as an infectious disease, the causative agent was discovered and characterized by efforts in the laboratories of Luc Montagnier-Maris and Robert Gallo in Bethesda. This immunodeficiency syndrome was novel at the time in that the type of virus causing it is a retrovirus. Retrovirus carry their genetic information in the form of RNA. When the virus enters a cell, the RNA is reverse transcribed to DNA by a virally encoded enzyme, reverse transcriptase or RT. As the name implies, RT reverses the normal transcription process and makes a DNA copy of the viral RNA genome. This copy, which is called a provirus, is integrated into the cell genome and is replicated along with the cell DNA. When the provirus is expressed to form new variants, the cell lyses. So alternatively, the previous provirus may remain latent in the cell until some regulatory signal starts the expression process. Only one other human retrovirus, human T-cell lymphotrophic virus 1 or HTLV1, had been described before HIV-1. Retrovirus is endemic in the southern part of Japan and the Caribbean. Although most individuals inhibited or infected with HTLV1 display no clinical signs of a disease, a small percentage develop serious illness, either adult T-cell leukemia, which is aggressive and usually fatal, or a disabling progressive neurologic disorder called HTLV1 associated myelopathy, or in early reports, tropical spastic paraparesis. Although comparisons of the genomic sequence reveal that HIV-1 is not a close relative of HTLV-1, similarities in overall characteristics lead to those of use of the name HTLV-3 for the AIDS virus in early reports. There is also a related human virus called HIV-2, which is less pathogenic in humans than HIV-1. HIV-2 is similar to viruses isolated from monkeys. It infects certain non-immune and non-human primates that do not become infected by HIV-1. Viruses related to HIV-1 have been found in non-human primates. These viruses, variant of simian immunodeficiency virus or SIV, cause immunodeficiency disease in certain infected monkeys. So normally SIV strains cause no disease in their normal host but produce immunodeficiency similar to AIDS when injected into another species. For example, the virus from African green monkeys is present in a high percentage of normal healthy African green monkey in the wild. However, when SIV-AGM is injected into macaques, it causes a severe, often lethal immunodeficiency. A number of other animal retrovirus, more or less similar to HIV-1, have been reported. These include the feline and bovine immunodeficiency virus and the mouse leukemia virus. Study of these animal viruses has yielded information concerning the general nature of retrovirus action, but specific information about HIV-1 cannot be gained by infecting animals because HIV-1 does not replicate in them. Only the chimpanzee reports infection with HIV-1 at a level sufficient to be useful in vaccine trials, but infected chimpanzees only rarely develop AIDS, which limits the value of this model in the study of viral pathogenesis. In addition, the number of chimpanzees available for such studies is low, and both the expense and the ethical issues involved in experiments with chimpanzee preclude widespread use of this infection model. The SCID mouse, we mentioned about that earlier, reconstituted with human lymphoid tissue for infection with HIV-1, has been useful for certain studies of HIV-1 infection, especially in the development of drugs to combat viral replication. Reasons for the limited host range of HIV-1 include not only the cell surface receptors required for entry of the virus into the host cell, but dependence of the virus on host cell factors for early events in its replication process, such as transcription and splicing of viral messages. For example, mouse cell transfected with genes that mediate expression of the human receptors for HIV-1 will not support HIV-1 replication because they lack other host factors. By contrast, cells from hamsters or rabbits transfected to express the human receptor support levels of virus replication similar to those seen in human cells. Despite some progress in understanding the factors needed for HIV-1 infection, no clear candidate for an animal model of HIV-1 infection exists. This lack of a suitable infection model hampers efforts to develop both drugs and vaccines to combat AIDS. So, in vitro studies revealed the HIV-1 replication cycle. AIDS virus can infect human T cells in culture, replicating itself and in many cases causing the lysis of the cell host. So much has been learned about the life cycle of HIV-1 from in vitro studies. The various proteins encoded by the viral genome have been characterized and the functions of most of them are known. The first step in HIV infection is viral attachment and entry into the target cell. So HIV-1 infects T cells that carry the CD4 antigen on their surface. In addition, certain HIV strains will infect monocytes and other cells that have CD4 on their surface. The preference for CD4 plus cell is due to high affinity interaction between a coat, envelope or ENV protein of HIV-1 and cell surface CD4. Although the virus binds to CD4 on the cell surface, this interaction alone is not sufficient for entry and protective infection. Expression of other cell surface molecules, co-receptors present on T cells and monocytes, is required for HIV-1 infection. So the infection of a T cell depicted assisted by the chemokine receptor CXCR4. The, an analog receptor called CCR5 functions for the monocyte or macrophage. After virus has entered the cell, the RNA genome of the virus is reverse transcribed and a cDNA copy integrates into the host genome. The integrated provirus is transcribed and the various viral RNA messages spliced and translated into proteins, which, along with a complete new copy of the RNA genome, are used to form new viral particles. The gag proteins of the virus are cleaved by the viral protease into the forms that make up the nuclear capsid in a mature infectious viral particle. As we will be soon describe, the discovery that CXCR4 and CCR5 serve as co-repressors co-receptors for HIV-1 on T cells and macrophages respectively explained why some strains of HIV-1 preferentially infect T cells or trophic strains, whereas others prefer macrophages. A trophic strain uses CXCR4, whereas the M trophic strain uses CCR5. This use of different co-receptors also helped to explain the different roles of cytokines and chemokines in virus replication. It was known from in vitro studies that certain chemokines had a negative effect on virus replication, whereas certain pro-inflammatory cytokines had a positive effect. Both of the HIV co-receptors CCR5 and CXCR4 function as receptors for chemokines. Because the receptors cannot bind simultaneously to HIV-1 and to their chemokine ligand, there is competition for the receptor between the virus and the normal ligand, and the chemokine can block viral entry into the host cell, whereas the chemokines compete with HIV for usage of the co-receptor and thus inhibit viral entry. The pro-inflammatory cytokines induce greater expression of the chemokine receptors on the cell surface, making the cell more susceptible to viral entry. HIV-1 infection of T cells with certain strains of virus leads to the formation of giant cells or syncytia. These are formed by the fusion of a group of cells caused by the interaction of viral envelope protein GP120 on the surface of infected cells with CD4 and the co-receptors on the surface of other cells, infected or not. After the initial binding, the action of other cell adhesion molecules welds the cells together in a large multinuclear mass with a characteristic fused ballonic membrane that eventually bursts. Formation of syncytia may be blocked by antibodies to some of the epitopes of the CD4 molecule. by soluble forms of CD4 molecule prepared in vitro expression of CD4 generally engineered to lack the transmembrane portion, and by antibodies to call cell adhesion molecules. So individual isolates of HIV-1 differ in their ability to induce syncytia formation. Isolates of HIV-1 from different sources were formerly classified as syncytia inducing or non-syncytium inducing. In some cases, these differences correlates with the ability of the virus to infect T cells or macrophages. T-trophic strains were SI, whereas M-trophic strains were NSI. More recent classification of HIV-1 are based on which core receptor the virus uses. There is good but not absolute correlation between the use of CXCR4, which is present on T cells, and syncytia inducing ability. The HSI strains use CCR5, which is present on monocytes. Studies of the viral envelope protein GP120 identified a region called the V3 loop, which plays a role in the choice of receptor used by the virus. A study by Mark Goldsmith and Bruce Chesebro, and I'm not sure about the pronunciation of the scientists of their colleagues, indicated that a single amino acid difference in this region of GP120 may be sufficient to determine which receptor is used. So HIV-1 infection leads to opportunistic infections. Isolation of HIV-1 and its growth in culture has allowed purification of viral proteins and the development of tests for infection with the virus. The most commonly used test is for the presence of antibodies directed against proteins of HIV-1. These generally appear in the serum of infected individuals by the 3 months after the infection has occurred. When the antibodies appear, the individual is said to have seroconverted or to have seropositive for HIV-1. Although the precise cause of HIV-1 infection and disease onset varies considerably in different patients, a general scheme for the progression of AIDS can be constructed. The course of HIV-1 infection begins with no detectable anti-HIV-1 antibodies and progress to the full AIDS syndrome. Diagnosis of AIDS include evidence for infection with HIV-1, presence of antibodies or viral RNA in blood, greatly diminished numbers of CD4 plus T cells, impaired or absent delayed hypersensitivity reaction, and the occurrence of opportunistic infections. Patients with AIDS generally succumb to tuberculosis, pneumonia, severe wasting, diarrhea, or various malignancies. The time between acquisition of virus and the death from the immunodeficiency averages 9 to 12 years. In the period between infection and severe disease, there may be few symptoms. Primary infection in a minority of patients may be symptomatic with fever, lymphadenopathy, swollen lymph nodes, and a rash, but these symptoms generally do not persist more than a few weeks. Most commonly, primary infection goes unnoticed and is followed by a long chronic phase during which the infected individual shows little or no overt sign of HIV and infection. The first overt indication of AIDS may be opportunistic infection with the fungus Candida albicans, which causes the appearance of sores in the mouth, and in women, a vulvovaginal yeast infection which does not respond to treatment. A persistent hacking cough caused by P. carini infection of the lungs may also be an early indicator. Rise in the level of circulating HIV-1 in the plasma and concomitant drop in the number of CD4 plus T cells generally previews this first appearance of symptoms. Some relation between the CD4 plus T cell number and the type of infection experienced by the patient has been established. Of intense interest to immunologists are the events that take place between the initial confrontation with HIV-1 and the takeover and collapse of the host immune system. Understanding how the immune system holds HIV-1 in check during this chronic phase may lead to the design of effective therapeutic and preventative strategies. So, research into the process that underlie the progression of HIV infection to AIDS has revealed a dynamic interplay between the virus and the immune system. The initial infection event causes dissemination of virus to lymphoid organs and resultant strong immune response. A common means by which virus is disseminated from the initial point of contact to lymphoid organs, where it can contact activated T cells and begin a productive replication cycle, is probably via dendritic cells. So, dendritic cells may pick up virus and bring it to the T cell rich areas and provide the cause stimulation needed to activate the T cell and render it an appropriate host for HIV-1 infection. Direct observation of HIV-1 at the site of T cell dendritic cell interaction supports the possibility of this mechanism for initial spread of HIV-1 following exposure. Following exposure of the lymphoid tissue to virus, an immune response involving both the antibody and cytotoxic CD8 plus T lymphocytes keeps viral replication in check after the initial burst of viremia. So, following exposure of the lymphoid tissue to virus, an immune response involving both the antibody and cytotoxic CD8 plus T lymphocytes keeps viral replication in check. After the initial burst of viremia, high levels of virus in the circulation, the viral level in the circulation achieves a steady state. Although the infected individual normally has no clinical signs of disease at this stage, viral replication continues and virus can be detected in circulation by sensitive PCR assays for viral RNA. These PCR-based assays, which means viral load, a number of copies of viral genome in the plasma, have assumed a major role in the determination of the patient's status and prognosis. Even when the level of virus in the circulation is stable, large amount of virus are produced in infected CD4 plus T cells. As many as 10 raised to minus virions are released every day and continually infect and destroy additional host T cells. Despite this high rate of replication, the virus is kept in check by the immune system throughout the chronic phase of infection, and the levels of virus in circulation from about 6 months after infection is a good predictor of the cause of disease. Low levels of virus in this period correlate with longer time in which the infected individual remains free of opportunistic infection. But in the absence of treatment, the virus eventually overcomes host immune defenses, resulting in an increase in viral load above the steady state level, a decrease in CD4 plus T cell numbers, increased opportunistic infection, and eventually death of the patient. Although the viral load in plasma remains fairly stable throughout the period of chronic HIV infection, examination of the lymph nodes and gastrointestinal tract tissue reveals a different picture. Fragments of nodes obtained by biopsy from infected subjects show high levels of infected cells at all stages of infection. In many cases, the structure of the lymph node is completely destroyed by virus long before plasma viral load increases above the steady state level. Recent data from the laboratories of Ashley Haas and Daniel Doug indicate a dramatic depletion of CD4 plus T cells from the gastrointestinal tract, lymph nodes, and peripheral blood during the chronic phase of infection. The decrease in CD4 plus T cells is the hallmark of AIDS. Several explanations have been advanced for the depletion of T cells in patients. In early studies, direct viral infection and destruction of CD4 plus T cells was discounted as the primary cause because the large number of circulating HIV infected T cells predicted by the model were not found. More recent studies indicate that the reason for the difficulty in finding the infected cells is that they are so rapidly killed by HIV. The half-life of an actively infected CD4 plus T cell is less than 1.5 days. Smaller numbers of CD4 plus T cells become infected but do not actively replicate virus. These latently infected cells persist for long periods, and the integrated proviral DNA replicates in cell division along with cell DNA. Studies in which viral load is decreased by antiretroviral therapy show a recurrent increase in CD4 plus T cell numbers in the peripheral blood. These data support a number of dynamic interaction between virus and T cells with simultaneous high levels of viral production and rapid depletion of infected CD4 plus T cells. Although other mechanisms for depletion of CD4 plus T cells may be envisioned, infection with HIV remains the prime suspect. Not only depletion of CD4 plus T cells, but other immunologic consequences can be measured in HIV infected individuals during the progression to AIDS, including a decrease or absence of delayed hypersensitivity to antigens to which the individual normally reacts. Serum levels of immunoglobulins, especially IgG and IgA, show a sharp increase in the AIDS patient. This increase may be due to increased levels in HIV-infected individuals of a B cell subpopulation with low CD21 expression and enhanced immunoglobulin secretion. This population proliferates poorly in response to B cell mitogens. Cellular parameters in immunologic response, such as the proliferative response to mitogens, to antigens, or to alloantigens, all show a marked decrease. Generally, the HIV-infected individual loses the ability to mount T cell response in a predictable sequence. So, response to specific antigens, for example, influenza virus, are first lost. Then, response to alloantigens decline, and last, the response to mitogens such as concavalin A or phytohemagglutinin can no longer be detected. So, individuals infected with HIV-1 often display dysfunction of the central and peripheral nervous system. Specific viral DNA and RNA sequences have been detected by HIV-1 probes in the brains of children and adults with AIDS, suggesting that viral replication occurs there. So, quantitative comparison of specimens from brain, lymph node, spleen, and lung of AIDS patients with progressive encephalopathy indicated that the brain was heavily infected. A frequent complication in later stages of HIV infection is AIDS dementia complex, a neurologic syndrome characterized by abnormalities in cognition, motor performance, and behavior. Whether AIDS, dementia, and other clinical and histological effects observed in the central nervous system of HIV-infected individual are a direct effect of viral antigens on the brain, a consequence of immune response to the virus, or a result of the opportunistic effects remains unknown. Therapeutic agents inhibit retrovirus replication. Development of a vaccine to prevent the spread of AIDS is the highest priority for immunologists, but it is also critical to develop drugs and therapies that can reverse the effects of HIV-1 in infected individuals. The number of HIV-infected people is estimated to be close to 1 million in the United States alone. For all of these individuals to develop AIDS would be an enormous tragedy. There are several strategies for development of effective antiviral drug. The life cycle of HIV shows several susceptible points that might be blocked by pharmaceutical agents. The key to success of such therapies is that they must be specific for HIV-1 and interfere minimally with normal cell process. Thus far, two types of antiviral agents have found their way into common usage. The first success in treatment was with drugs that interfere with the reverse transcription of viral RNA to cDNA. Several drugs in common use operate at this step. A second stage of viral replication that has proved amenable to blockade is the step at which precursor proteins are cleaved into the units needed for construction of a new mature virion. This step requires the action of a specific viral protease, which can be inhibited by chemical agents, precluding the formation of infectious viral particles. A third type of drug recently licensed for use, that enfuviridate, brand name Fusion, is a fusion inhibitor that prevents the virus from entering target cells. The prototype of the drugs that interfere with reverse transcription is zidovudine or AZT, azidothymidine. The introduction of AZT, a nucleoside analog, into the growing cDNA chain of the retrovirus causes termination of the chain. AZT is effective in some but not all patients, and its efficacy is further limited because long-term use has several adverse side effects and because resistant viral mutant develop in treated patients. The administered AZT is used not only by the HIV-1 reverse transcriptase but also by human DNA polymerase. The incorporation of AZT into the DNA of host cell kills them. Precursors of red blood cells are especially sensitive to AZT, resulting in anemia and other side effects. A different approach to blocking reverse transcription employs drugs such as nevirapine and delavirdine, which inhibit the action of the reverse transcriptase enzyme. A second class of drugs called protease inhibitors has proven effective when used in conjunction with AZT and or other nucleoside analogs. Current treatment for AIDS is a combination therapy using regimens designed HART, highly active antiretroviral therapy. In most cases, this combines the use of two nucleoside analogs and one protease inhibitor. The combination strategy appears to overcome the ability of the virus to rapidly produce mutants that are drug resistant. In many cases, HART has lowered plasma viral load to levels that are not detectable by current methods and has improved the health of AIDS patients to the point that they can again function as a normal level. At a normal level, the decrease in the number of AIDS deaths in the United States in recent years is attributed to this advance in therapy. Despite optimism endangered by success with HART, present drawbacks include a strict time schedule of administration and a large number of pills to be taken every day. In addition, there may be serious side effects. Some patients may be too severe to allow use of HART. The success of HAART in treating AIDS has opened a discussion of whether it might be possible to eradicate all virus from the infected individual and thus actually cure AIDS. Most AIDS experts are not convinced that this is possible, mainly because of the persistence of latently infected CD4 plus T cells and macrophages, which can serve as a reservoir of infectious virus if the pro-virus should be activated. Even with a viral load beneath the level of detection by PCR assays, the immune system may not recover sufficiently to clear virus should it begin to replicate in response to some activation signal. In addition, virus may persist in sites such as the brain, not readily penetrated by the antiretroviral drugs, even though the virus in circulation is undetectable. The use of immune modulators such as recombinant IL-2 in conjunction with HART is being examined as strategies to help reconstitute the immune system and restore normal immune function. In addition to the newly licensed fusion inhibitor enfortumab, which acts as a stage of viral attachment to the host cell, other drugs are in various stages of development. One promising class of drugs interfere with the interaction of the viral DNA into the host genome. It should be stressed that the development of any drug to the point at which it can be used for patients is a long and arduous procedure. The drugs that pass the rigorous tests for safety and efficacy represent a small fraction of those that receive initial consideration. A vaccine may be the only way to stop the HIV/AIDS epidemic. The AIDS epidemic continues to range despite the advance of therapeutic approaches outlined above. The present expense of HAAT is as much as $15,000 per year. The strict regime required and the possibility of side effects precluded universal application. Even if eradication of the virus in individuals treated with combination therapy becomes possible, it will not greatly influence the epidemics in developing countries, which include the majority of AIDS victims. It is likely that effective, inexpensive, and well tolerated drugs will be developed in the future, but at present it appears that the best option to stop the spread of AIDS is a safe, effective vaccine that prevents infection and progression to disease. Why don't we have AIDS vaccine? The best answer to this question is to examine the special conditions that must be addressed in developing a safe, effective vaccine for this disease. Most effective vaccines mimic the natural state of infection. Individuals who recover from most diseases are immune from subsequent attacks. The infection of HIV-1 and progression to immunodeficiency syndrome flourishes even in the presence of circulating antibodies, detected against proteins of the virus. Immunity may hold the virus in check for the time, but as mentioned above, it rarely exceeds 12 years in untreated HIV-1 infected people. In a rare subset of infected individuals called long-term non-progressors, the period of infection without disease is longer, even infinite. Another group for whom immunity seems to function are those who are persistently exposed but who remain seronegative. In this category are a low percentage of commercial sex workers in areas of high endemic infection, such as Nairobi, who have not become infected despite multiple daily exposure to infected individuals. Because of state of immunity, which antibodies are present and what type of cellular immunity is active in these individuals is not clear or consistent, it is difficult to duplicate for vaccine development. Certain of the long-term non-progressors or exposed and non-infected individuals have mutations or deletions in genes encoding cell co-receptors that slow the progression of viral attack on their immune system rather than an immune response that is holding HIV replication in check. Most vaccines prevent a disease, not infection. Polio and influenza vaccine hold the virus produced by infected cells in check so that it does not cause harm to the host, and it is then cleared. So HIV-1 does not fit this model because it integrates into host genome and may remain latent for long periods. As described above in the context of treatment strategies, eradication of a retrovirus is not a simple matter. Clearance of a retrovirus is difficult goal for a vaccine. Every copy of the virus and every infected cell, including those latently infected, must be eradicated from the host. However, even without complete eradication, an HIV vaccine may benefit the infected individual, and a vaccine that caused a lowered viral load could help to control the spread of infection. A recent study in Uganda, unmatched full infection, showed that low viral load in the infected partner inhibited spread of the uninfected mate. So most vaccines prevent infection by viruses that show little variation. The instability of its genome differentiates HIV-1 from host most viruses for which successful vaccines have been developed, with the exception of influenza, for which the vaccine must be changed periodically. Most viruses that can be controlled by immunization show only minor variability in structure. For comparison, consider that the retrovirus that cause the common cold have more than 100 subtypes. Therefore, no effective vaccine has been developed. So, HAV1 show variation in most viral antigens, and the rate of replication may be as high as 10 raised to 9 viruses per day. This variability, along with high rate of replication, allows the production of viruses with multiple mutations. Some of these allow escape from immunity. The fact that significant differences in viral envelope protein sequences have been seen in viral isolates taken from the same patient at different times indicate that variation occurs and that some of the variants replicate, presumably because they have learned to evade host immune defenses, that are showing that antibody from advanced stage patients will not neutralize virus isolated from that patient but will kill other strains of HIV-1, argues that HIV-1 does evade the immune system by mutation of proteins targeted by antibody. The majority of successful vaccines are live attenuated or heat killed organisms, although there are exceptions to this, notably the recombinant protein used for hepatitis B vaccine and the conjugate used for Haemophilus influenzae B vaccine. Most of the widely used vaccines are attenuated organisms. The development of a live attenuated retrovirus vaccine from animal viruses engineered to include HIV antigens is a possible route. However, the use of live vaccines is predicted on the supposition that the immunity raised will clear the vaccine virus from the host. It is not easily done for a retrovirus which integrates into the host genome. A massive testing effort would be required to ensure that a live retroviral vaccine was safe and did not cause chronic host infection. On the positive side, clinical studies using other other viruses such as attenuated vaccinia or canarypox as carriers for genes encoding HIV proteins have passed phase 1 safety trials and have advanced to phase 2 or efficacy trials. For most viruses, the frequency of exposure to infection is rare or seasonal. In many high risk individuals, such as commercial sex workers, monogamous of HIV infected subjects, and Intravenous drug uses. The virus is encountered frequently and potentially in large doses. An AIDS vaccine is thus asked to prevent infection against a constant attack by the virus or by massive doses of virus. This is not normally the case with other viruses for which immunization has proved successful. So, most vaccines protect against respiratory or gastrointestinal infection in addition to the frequency of exposure to HIV, which may be extraordinarily high for some high risk individuals. There is also the question of route. The majority of successful vaccines protect against viruses that are encountered in respiratory and gastrointestinal tracts. The most common route of HIV-1 infection is by the genital tract. It is not known whether the immune established by conventional vaccination procedures will protect against infection by this route. Although the lack of completely relevant animal model precludes in-depth test of protection, preliminary vaccine studies using rectal-vaginal challenge of immunized primates with SIV, HIV chimeric viruses slow protection to this challenge route. The development of most vaccines through to clinical trials relies on animal experiments. So, testing a vaccine for safety and efficacy normally involves challenge of an animal with a virus under conditions similar to those encountered in the human. In this way, the correlate with protective immunity was established. For example, a high titers of CD8 plus T cells and neutralized antibody are necessary for protection in an animal. Then CD8 plus T cell community and antibody should be measured in human trials of the vaccine. Thus far, animal studies of HIV infection and disease have yielded only a few hard facts about immune response that are protective against infection or that prevent progression to disease. Many results involve a specific virus in a particular host and are not easily extrapolated to universal concepts because they depend on host factors as well as the relationship between the immunizing and the challenging strains of virus. However, experiments have shown that passive immunization with antibodies taken from HIV infected chimpanzees protect mosquitoes from challenge with HIV strains bearing HIV enveloped glycoprotein. Further indication that antibodies can prevent infection is given by studies in which monoclonal antibodies protected macaques from a general challenge with SHIV. In such cases, the antibodies needed to be present at the time of challenge. Post-challenge administration of antibodies was not effective in preventing infection. Although there are no reports of greater success in human HIV vaccine trials, research in this difficult area continues to be active. Despite a massive effort, progress remains slow. Numerous products are undergoing testing at early stage in human volunteers. Approximately 13 proteins, DNA vaccines, and recombinant viruses are being tested in phase 1 trials for safety and immunogenicity, and about 5 candidates have progressed to phase 11 trials, which involve larger populations and, in some cases, high risk volunteers. The scale of the risk to bring a vaccine candidate to a phase 3 trial is reflected in the evaluation of a recent phase 3 test of 2 subunit vaccines. The tests took place after 20 years of research and development and cost about $300 million. They involved 78 clinics in 4 countries with the 1,35,000 patient visits. Although no protection was observed in vaccines, the tests were hailed by some as proof that such a large effort can be undertaken and coordinated, and that lessons learned will allow successful tests of promising products. In addition to developing a scientific rationale, behavioral and social issues influencing the development and testing of candidate AIDS vaccines, counseling, part of care given to volunteers in a vaccine trial, will thus influence the results. Would a lowering of infection rate in all groups taking part in the trial preclude seeing a meaningful difference in the infection rate between the vaccine and the placebo groups? A further consideration is the fact that anyone successfully immunized against the AIDS virus will become seropositive and will test positive in the standard screening assays for infection. What ramification will this have? Will the more complex viral load assays be needed to ascertain whether an immunized individual is actually infected? So it is clear that development of an AIDS vaccine is not a simple exercise in classic vaccinology. More research is needed to understand how this viral attack against the immune system can be thwarted. Although much has been written about the subject and large-scale initiatives are proposed. The path to the effective action is not obvious. It is certain only that all data must be carefully analyzed and that all possible means of creating immunity must be tested. This is one of the greatest public health challenges of our time, and intense and cooperative effort will be required to devise, test, and deliver a safe and effective vaccine. So now let's have a quick summary. Immunodeficiency results from the failure of one or more components of the immune system. Primary immunodeficiencies are present at birth. Secondary or acute immunodeficiencies arise from a variety of causes. Immunodeficiency may be classified by the cell types involved and may affect either the lymphoid or the myeloid cell lineage or both. The gene defects that underlie primary immunodeficiency allow precise classification. Genetic defects in molecules involved in signal transduction or in cellular communication are found in many immunodeficiencies. Lymphoid immunodeficiencies affect T cells, B cells, and NK cells, or all of these. Failure of thymic development results in severe immunodeficiency and can hinder normal development of B cells because of the lack of cellular cooperation. And myeloid immunodeficiency causes impaired phagocytic function. Those affected suffer from infected susceptibility to bacterial infection. Then severe combined immunodeficiency or SCID always involves T cell dysfunction and results from a number of different defects in the lymphoid lineage, and it is usually fatal. Then selective immunoglobulin deficiencies are a less severe form of immunodeficiency and result from defects in more highly differentiated cell types. Immunodeficiency will be treated by replacement of the defective or missing protein, cells, or gene. Administration of human immunoglobulin is a common treatment. Animal models for immunodeficiency include nude and SCID mice. Gene knockout mice provide a means to study the role of specific genes on immune function. Secondary immunodeficiency results from injury or infection, and the most common form is HIV caused by a retrovirus, human immunodeficiency virus 1. So this infection results in severe impairment of immune function marked by depletion of CD4 plus T cells and death from opportunistic infection. And treatment of HIV infection with antiretroviral drugs can cause lowering of viral load and relief from infection, but no cures have been documented. Efforts to develop a vaccine for HIV have not yet been successful. The millions of new infections in the year 2005 emphasize the need for an effective vaccine, and that area is open for research.